Hello everyone, welcome to this fourth IHS webinar. My name is Henrik Schütz. I'm co-chair of the Education Committee in IHS, and my co-host tonight is Dr. Anna Andreu, who is Director of Headache Research at the Headache Centre at Guy's and St. Thomas in London, and she's also the chair of the Electronics Media Committee. Thank you so much for joining, Anna.
Hello and welcome everyone.
The topic of this webinar, which I look very much forward to, is trigeminal neuralgia, and we'll also talk about other cranial neuralgias and facial pain. And we're so lucky we have two world experts, Dr. Lars Benson and Dr. Giorgio Lambrou, who will share their knowledge on this topic. And we'll start with the two lectures, and then we'll have a Q&A session where we'll try to go over as many questions as we can. So kindly write questions via the Q&A button that you see at the bottom of your screen. Kindly state your name and where you're from. And now we'll hear the first speaker, who is Dr. Lars Benson, and he'll give an overview of trigeminal neuralgia. Dr. Lars Benson is a neurologist, associate professor and co-director at the Danish Headache Centre in Copenhagen, Denmark. Among Lars Benson's research interests are the pathophysiology and management of headache, and he's also been chairman on several international guidelines, including the recent EN guideline on trigeminal neuralgia. Lars, thank you so much for speaking and sharing your knowledge on trigeminal neuralgia, and I look very much forward to the lecture.
Thank you, Henrik and Anna, for allowing me to join this webinar. I've been looking much forward to that. I will try to share my screen now. Can you see it? I guess so. Well, so the topic of my talk is trigeminal neuralgia, and I will mainly focus on the clinical aspects, diagnosis and treatment. And these are my disclosures. I will recommend that if you are interested in to go more in details with this topic, that you look at the recent guidelines from the EAN, as Henrik just mentioned, where an expert group, they have looked at 10 very important clinical questions, and it was published 2 years ago in the EAN. So let's start out with a case. We have a 71-year-old man. 2 years ago, he started having persistent pain in the second and third branch of the trigeminal nerve. And a few months later, he experienced frequent intense pain paroxysms in the same area. So what more information do we need to find out whether this is trigeminal neuralgia or other kind of facial pain? Well, we need to know something about the duration of the pain, the quality, are there trigger factors? What about dentists? Have there been a dentist checkup? Are there trauma, autonomic symptoms, the location of the pain, etc.? So this leads me to what are the diagnostic criteria. And the most recent diagnostic criteria from the IHS were published in 2018. And they state that to have the diagnosis of trigeminal neuralgia, you need to have recurrent paroxysms of unilateral facial pain, which follows the distribution of the trigeminal nerve. And it has to be a short-lasting pain, severe, and like electric shocks or stabbing quality. And then very important, there are trigger factors such as touching within the affected area, cold when speaking, that elicits these very, very severe pain paroxysms. And trigeminal neuralgia is the most known of the facial pains, but there are many others and very important differential diagnosis, but I will not come into this. This will Giorgio Lambrou speak about in the next talk. But the diagnosis here is can be difficult. So let's get back to our case. Now we took a history, and it actually revealed that this patient, he suffered from trigeminal neuralgia. He fulfilled all the criteria. But we need to give a more specific diagnosis. So what will the next step be for us to give a more specific diagnosis? Well, what we need here is MRI. And why do we need that? Because we need to find out whether this is a primary or secondary trigeminal neuralgia. And if it's a primary, it's very important for us to find out whether this is classical TN. That means that there's a vessel, usually the superior cerebellar artery, that compresses the nerve, or whether it is idiopathic. Either there's no neurovascular contact or just a simple contact, meaning that there's no compression of the nerve. This is really important. And this can then further be divided into a pure that is purely paroxysmal, and another one where there's also concomitant continuous pain. And then we have to rule out the secondary TNs, which are often caused by multiple sclerosis or maybe due to a tumor. Therefore, MRI is mandatory. And what about the pathophysiology? We know that the primary site of damage is peripheral, near the root entry zone, probably because the nerves, they change myelination from Schwann cells to oligoglia in this area. And this primary damage, it can be caused by compression, as I mentioned, by a vascular contact or a tumor, or by MS. Quite a large number of MS patients, they have TN. So we think that the pathophysiology is like this, that there will be a local de- and dysmyelination in the transition zone of the trigeminal nerve. This could lead to hyperexcitability, spontaneous impulses, and epileptic transmission of the pain. And this can ignite nociceptive afferents by innocuous sensory stimuli. And in this way, the sensory input to the cortex, it'll be this of a stabbing pain in the face. So what about this neurovascular contact? What is the importance of this? We know that a simple neurovascular contact is very prevalent. It can be seen in nearly 80% of asymptomatic nerves. So this, and maybe the most important statement that I will come with today, is that if you have a simple neurovascular contact, this does not mean that you have trigeminal neuralgia. We have a lot of patients referred with different kinds of facial pains, and because a simple contact has been demonstrated on the MRI, the specialists, they think that this is trigeminal neuralgia. It is not simply so. But we know that if there's a severe contact making the morphological changes of the nerve, then this is highly indicative of the classical TN, and we know that plays a major role for the pathophysiology. But important, simple NVC is not necessarily symptomatic. And this is how we look at the our TN patients. We always do it blinded so that our neurologists, they do not know the site of the pain. And we look at both the axial, the coronal, and the sagittal view of the brainstem. And here you can see patients with TN, and I guess, yes, you might be able to say on which side the pain is, but it'll get easier when you take the next slide. Now you can see where the pain is. You can see it's actually on the right side here. You can see here's a completely healthy nerve, and here this trigeminal nerve root is being compressed by the artery. You can see this very clearly now. The healthy nerve on the left side, and here on the right side there's a severe compression of the nerve. This is really beautiful pictures. You can really see where the pain comes from. You see here it's really compressed on this side. And when you look at the sagittal view, can you see the nerve and the vessel contact? Now it's getting more and more clear. Here you can clearly see the vessel. It's coming in and making a loop, compressing the nerve here. Here it's very obvious where the compression is. And then if we look at the coronal view, we can see the loop of the artery here. So that's what we're looking at when we're looking for this neurovascular contact. So in other words, the primary TM, it may or may not be caused by vascular compression. Symptomatic TN is usually caused by either a space occupying process or multiple sclerosis. and approximately 15% of our TN patients, they are symptomatic. Here you see a meningioma compressing the nerve, and you can see clearly on this picture that there's not much room for the nerve here. It's really being compressed by the meningioma. Okay, so now we know that this, we found out that our case here actually had a neurovascular contact with morphological changes on the symptomatic side. So the diagnosis will be, well, it will be classical TN, not idiopathic, but classical TN. So what now? How do we treat this patient? Do we need more information? Well, what we need is more about his medical history. The patient, he came to us, he had a lot of pain, he was very tired, he was treated with paracetamol 3,000 milligrams per day, tramadol 150 milligrams, and gabapentin 1,800 milligrams per day. He had not been offered other drugs. So what would you do with this patient? What we did was to stop paracetamol and tramadol because it usually has no effect in these patients, and the tramadol, it just makes the patient more tired. It's the same if it's other opioids. You should usually get rid of them in order to be able to increase the dosages of the drugs that actually work in TN. And that will, in this case, we would choose carbamazepine. You could also have chosen oxcarbazepine, but here we chose carbamazepine, and we kept the patient on the gabapentin until we were able to increase the carbamazepine so much that we could decrease the gabapentin. Okay, the patient, he was well controlled for 2 years on carbamazepine 600 to 1,200 milligrams per day, plus gabapentin 0 to 1,800 milligrams per day. And why do I write this, for example, 0 to 1,800 milligrams per day? Well, that's because it's very important to know that trigeminal neuralgia, it has usually there are good periods and bad periods. It's usually fluctuating. Means that if the patient comes into a good period, it's important that you try to decrease their medications, because usually these patients, they will have quite a lot of side effects on the medications. So when in the good periods, you should try to make them decrease the amount of medication. The problem here in these patients is that usually they are so afraid of getting the pain back that sometimes you really have to convince the patients to try to decrease if they have too many side effects. But they can be really frightened because they have so much pain. So it can be a problem, but you have to tell the patients that if the pain comes back, they can simply increase the dosages again. So after 2 years, we couldn't really control the pain anymore. He had more and more pain, even if we increased to carbamazepine 1,800 milligrams and to gabapentin 2,400 milligrams. He came to our clinic and he had lost 5 kilos the last 2 weeks. He could not eat and drink. What to do? What would you do in this case? Well, what we had to do was simply to admit the patient to hospital, and we gave him acute intervention of phosphonatrine. And it was effective, but you need to do this in the during cardiac monitoring. And in the recent guidelines, there's a weak recommendation, and the reason why it's weak is that there's nearly no evidence for this, but it's clinical experience that it is effective. So about the acute treatment, simple analgesics and opioids usually have no effect. This pain can be so severe that it is impossible to eat, drink, and take medications. And if you need acute intervention, you could consider infusion of phosphonatrine, and we do it in the same way as we do for status epilepticus. And others have also used lidocaine. It can also be effective. So what about the long-term medical treatment? How do we optimize that? We know that the first drugs of first of line is carbamazepine or oxcarbazepine. And usually we try one of these first, and if it doesn't work, we switch to the other, and you switch directly from carbamazepine 200 milligrams. It give the same effect as oxcarbazepine 300 milligrams. So you can switch directly between these drugs to find out which is the most effective. And then usually in our clinic, if this is not effective, then we will usually add other drugs, such like lamotrigine, gabapentin. We also use Botox quite a lot for these patients. You could use pregabalin, baclofen, or phenytoin. And as I mentioned before, it is important to adjust the dosage according to the severity of the pain and to the side effects. Okay, back to our patient. The pain was well controlled on carbamazepine and gabapentin for 1 more year. After this, we could not control the pain anymore. So what to do? Then you have to consider surgery. And usually we recommend that medical management, it should be tried before surgery. In most centers, about 2/3 of the patients, they can be controlled on medications, and 1/3 they need surgery. And surgery should definitely be considered if the patient is not properly controlled medically. If patient has classical TN, that is, if there's a neovascular contact causing morphological changes, then microvascular decompression is first choice. In patients with idiopathic, you could choose either microvascular decompression if there's some kind of contact, or you could use the so-called ablative treatments, such as balloon compression, gamma knife, and glycerol lysis. I'll not go into detail with this picture. It's just photos taken from MVD operation by our neurosurgeons, where you can see the trigeminal nerve and the artery which is removed, and there's put a piece of Teflon in between the artery and the nerve. So what do we know about microvascular decompression? Unfortunately, there are no good prospective studies yet, so we have to rely on retroprospective studies, and these indicate that it is effective in about 3/4 of the patients. There may be some complications, such as cranial nerve palsy, sensory loss, or brainstem stroke. So there are complications, but we need some better prospective studies to evaluate this. So in our patients, the MRI demonstrated neovascular contact with morphological changes on the symptomatic side, and our patient had actually performed microvascular decompression with a good result. The so-called neuroablative treatments is, as I mentioned before, radiosurgery, injection of glycerol, inflation of a balloon, or thermocoagulation. We don't know exactly how effective they are, perhaps in a little less than 50%. The main complications are sensory disturbances. So to conclude on the management, primarily prophylactic pharmacological treatment is with anti-epileptics. Simple analgesics and opioids usually have no effect. If there's an acute aggravation, it is possible to interrupt these with phosphoenolate infusion. Remember that spontaneous remission and aggravation is very frequent, and to adjust the dosage according to severity of the pain and according to side effects. If you cannot control the patient with medical treatment, you should definitely consider surgical treatment. You can use either microvascular decompression or the neuroablative treatments, but microvascular decompression provides longest duration of pain freedom. So that should be chosen if you have a significant neovascular contact. That was what I had to say now. We should also, I've promised Henrik and Anna that we will give some time for question and answers. Thank you for your attention.
Thank you, Lars. Very nice presentation. Thank you so much indeed. Yes, just a quick reminder that we will answer all questions at the end. And please keep typing your questions in the Q&A option in your Zoom. I will now introduce Dr. Giorgio Lambro, who is our next speaker. Dr. Giorgio Lambro is a consultant neurologist and honorary senior lecturer at Guy's and St. Thomas's NHS Foundation Trust in London. He runs one of the largest centers of complex headache and facial pain services in UK. Dr. Lambro.
Thank you, Anna. I hope you can hear me all right, and welcome to everyone. Let me share my screen, and then we can make a start. I hope you can see all right. Let me just, can you hear me all right? Yeah? Okay. So I thank you for inviting me. I think it's I'm very pleased to give this lecture, and I'm very pleased to see that there are so many people attending from all over the world. I think it's really important for the IHS to give the adequate time for facial pain and cranial neuralgia, which is a branch of medicine that needs much more attention and needs much more research. And I think the reason is because we know very little about it, and we need more to do more for our patients. So I hope that after lectures like this, there will be some people that can form MDTs and try to work together to try and disentangle the complexity of some of these cases. So I will continue on Lars' lecture on trigeminal neuralgia, talking about the other cranial neuralgias and in general about facial pain towards the end. So, one of the main problems is because we know very little about the biology of facial pain, the classification has been changing over time, and it has been quite complex, because sometimes the focus is on the biology, sometimes the focus is on the clinical characteristics, and so that has created confusion, and confusion is not great when it comes to, sorry, I think my connection is not great when it comes to trying to study a certain population. But we know that facial pain is can be classified as neurovascular when it comes to primary headaches like migraine and the trigeminal autonomic cephalalgias, for example. You know that a proportion of them can present with facial pain, and very rarely they can present exclusively with facial pain. It can be neuropathic. So we are talking about the cranial neuralgias, and we know that there are similar condition when the dysfunction of the nerve is constant, and there is a clear cause for it, quite often traumatic, inflammatory, viral, and then that can give rise to a cranial neuropathy. And then burning mouth syndrome, which is considered a neuropathic condition. And then we've got the idiopathic one. Idiopathic because we don't really know what the pathophysiological mechanism underlying the pain and the other symptoms are. And they include persistent idiopathic facial pain and temporomandibular joint disorder. So when it comes to the IHS classification, if you look at the way they classified the neuralgias, other than trigeminal neuralgia, essentially they follow what Lars has just explained to us. So they look at the MRI findings of the cranial nerve in particular, and of course, if there is a secondary process, brain disease is considered secondary. Otherwise, you look at the significance of the neurovascular conflict, and the neuralgia is considered classical if the neurovascular compression causes morphological changes to the nerve, or idiopathic if there is no changes, or if the neurovascular conflict is only mild. When it comes to neuropathy, we've got neuropathy caused by trauma, viral infection, quite often herpes zoster, for example, inflammatory condition like MS, tumors or other pathologies of the posterior fossa. And in a small proportion of people, we don't find any cause, any drive with our neuroimaging, and so we can classify them as idiopathic. Now, if you start talking about glossopharyngeal neuralgia, so I think you need to keep in mind that if trigeminal neuralgia is rare, what I'm going to talk about now is very rare. Okay, so but it's important. It's important to know because when you run a facial pain clinic, you need to be aware of all the possible differential diagnoses because sometimes the anatomy overlaps, the function overlaps, and then you can run into troubles and make the wrong diagnosis and offer the inappropriate treatment. So glossopharyngeal neuralgia is a neuralgia, so it's characterized by paroxysmal, very severe pain episodes following the sensory distribution of the glossopharyngeal nerve and the vagus nerve. And you can see on the right the sensory distribution, sensory afferents. Glossopharyngeal neuralgia has got a female preponderance, and as I was saying, is very rare. So let's say 1% of the facial pain syndromes and 0.8 per 100,000. So if you look at the distribution of the sensory nerves, you know where the pain, if there is a dysfunction of the glossopharyngeal nerve, can be. So we're talking about the posterior part of the tongue, the pharynx, the middle ear, and it's important to know that the nucleus receives chemoembaroreceptors from the carotid bodies, and that's important when it comes to the potential symptoms related to glossopharyngeal neuralgia. We talk about that in the next slide. It's important to know that the glossopharyngeal nerve has got parasympathetic and motor fibers, especially to the stylopharyngeal muscle, which is important for talking and swallowing. And that's those are some of the most common trigger factor for glossopharyngeal neuralgia. Now, if you look at the criteria, so we have discussed the pain location, which is crucial, okay? So ear, base of the tongue, the tonsillar fossa, and the angle of the jaw. The other characteristics are very similar to any other neuralgias. The important difference here is the triggers. So swallowing is typical of glossopharyngeal neuralgia. Coughing, talking is, overlaps with other neuralgias, and yawning is quite typical of glossopharyngeal too. As most of the cranial neuralgias, the pattern is relapsing remitting. So it comes, it stays for weeks or months, then it disappears completely for no apparent reason. And then with a very erratic pattern, it may relapse again for months, for weeks and months. And because of the innervation of the carotid body, 10% of the patient will present with some vagal symptoms, such as syncope or bradycardia. So it's important to look at this aspect when you phenotype someone with possible glossopharyngeal neuralgia. As most of the neuralgias, the pain is predominantly unilateral. Technically, there shouldn't be any interictal pain, but sometimes, at least I've had a few patients with interictal pain. The other thing is, if you look at the series of glossopharyngeal neuralgia, you can find that there are other triggers that can be quite overlapping with the other cranial neuralgias. And so the differential diagnosis becomes really interesting, and I think is one of the most fascinating part of our job. Try to understand, try to link the anatomy to the symptoms, and try to see whether we can come to a diagnosis. Because as you probably have experienced, sometimes these neuralgias can overlap, and if they overlap, you sometimes have to think about a more central problem rather than a peripheral problem. But if you look at the secondary cases of glossopharyngeal neuralgia, we've got the compressive, we've got the secondary ones, which means that pretty much everyone that's got a probable glossopharyngeal neuralgia needs to see an ENT or a maxillofacial surgeon, and they have to have a comprehensive MRI study of the brain, the skull base, the glossopharyngeal and trigeminal nerves. You need to rule out that there isn't a oropharynx tumor. Okay, so that's really important. Rule out inflammatory conditions too, and there is a particularly rare condition called Eagle syndrome that can be put in differential diagnosis. When it comes to primary glossopharyngeal neuralgia, so let's suppose that you have done all of that, and you think you've got glossopharyngeal neuralgia, you think it's a primary process, then you have to think about trigeminal neuralgia as a differential diagnosis. Superior laryngeal neuralgia, which is a branch of the vagus nerve, which can cause throat pain. And so that's also important to be put in differential diagnosis. And nervus intermedius neuralgia because of the otalgia related to it, so the ear pain. So Eagle syndrome, I just want to quickly mention it because I think it's one of these diagnoses that is very often mentioned, but the reality is that it's vanishingly rare. And actually, not only is rare, is a very unclear condition with an unclear pain mechanism. Because the idea is that this patient has got an elongated styloid process, normally by let's say more than 5 centimeters, where the normal length is 2.5 to 3, and so they can have pain in the ear jaw area, angle of the jaw, and that can present as otalgia, pain radiating to the anterior part of the neck. It can be triggered by yawning and chewing. So there are some overlapping characteristics with glossopharyngeal neuralgia. And it can give this typical sensation. The patient that I had report a foreign body sensation, which is quite interesting. So they clearly need an ENT maxillofacial assessment. But again, if you look at the CT neck studies, the prevalence of elongated styloid process exceeds quite significantly the pain related to it. Okay, to the point that some people argue whether the Eagle syndrome actually is a syndrome or is an overdiagnosis. But again, the way we address it clinically, there are some medical treatments. You can do a block in the area, and if the pain goes, then perhaps you can sort of that can support the diagnosis further, and then potentially you can do a steroidectomy, and that is supposed to reduce the pain. Now, when it comes to differential diagnosis of glossopharyngeal neuralgia, so I think in terms of the pain characteristics, there are many differences apart from the vasovagal symptoms that are typical of GFN. When it comes to the site, so the anatomical distribution, that's really important, okay? So angle of the jaw can be overlapping between trigeminal neuralgia, glossopharyngeal, and nervus intermedius, but we know that throat pain is more typical for glossopharyngeal, and ear pain should be more typical for glossopharyngeal and nervus intermedius and not for trigeminal neuralgia. The duration is very much similar. The triggers are different. We mentioned swallowing, and that has to be your focus when you try to discriminate the conditions. Treatment is pretty much similar, and surgery, microvascular decompression, is also effective in glossopharyngeal neuralgia. So that's also quite similar, although the evidence are much less robust than in trigeminal neuralgia. And this is the treatment paradigm. We use the usual antineuropathic. We can use an ultrasound-guided blockade, and that can also be effective long-term in some people. Normally it's ultrasound-guided, but it can be X-ray guided. And then in those who are refractory, we can, if there is a neurovascular conflict with the glossopharyngeal nerve, we can use microvascular decompression. We now are using more often in the endoscopic technique, which is, it gives a better view of the area, and it seems to be slightly less invasive. And the response rate is pretty good, although as you can see, the follow-up is very short. If there is no neurovascular conflict, then we go into this sort of territory of more destructive procedures that have got debatable evidence and very small case series. If we move to the nervus intermedius, I think that's important because quite often we see people with neuropathic otalgia. okay? And that's can be sometimes challenging in terms of the differential diagnosis. So nervus intermedius neuralgia is a very rare form of neuropathic otalgia, and it has to be treated as such, okay? So we're talking about a condition where people get a deep pain in the auditory canal, so it's not on the ear pinna, it's deep in. It can radiate to the mastoid angle of the jaw. The other characteristics are very similar to the other neuralgias, but the trigger is a stimulation of the posterior wall of the auditory canal or the periauricular region, which of course is not an immediate trigger. Because of the parasympathetic innervation of the lacrimal gland and the submandibular and sublingual glands, sometimes nervus intermedius neuralgia can be associated with some cranial autonomic features that we find in the trigeminal autonomic cephalalgias. And so it's quite important to keep that in mind when we phenotype someone with neuropathic otalgia, especially if it's paroxysmal. And that brings me to the differential diagnosis, and which is, I think, quite fascinating if you look at the complexity of the innervation of the ear. And we know that there are afferent branches of the auriculotemporal nerve, trigeminal, greater auricular nerve, C2, C3, nervus intermedius from the facial nerve, and the vagus and the glossopharyngeal nerves. And so the differential diagnosis is complex and is quite broad. We've got trigeminal neuralgia, especially if the pain starts from the ear area and then it shoots down, which though is atypical for nervus intermedius. We've got our glossopharyngeal neuralgia, but again, that's almost never just, the pain is almost never just focused over the ear. So there is the radiation of the posterior part of the tongue, pharynx, and so on and so forth. Cervicogenic headache. So there are some forms of C2, C3 where the pain actually is in the mastoid area and radiates to the ear, and so we need to take that into account. Like occipital neuralgia, for example, which is a form of cervicogenic headache, broadly speaking. There are some very rare cases of paroxysmal hemicrania presenting as otalgia responding to indomethacin. So really important. If you think that you've got your paroxysmal ear pain lasting 5 to 10 minutes, 2 minutes, 3 minutes, short lasting in the range of paroxysmal hemicrania, occurring multiple times a day with some level of autonomic activation, think about indomethacin. Of course, we need to rule out TMD, which is probably quite a difficult job. And remember, people with one neuralgia can have TMD as a contributing factor. So, you know, there could be more than one problem going on. And then if you probably have heard of red ear syndrome, if the pain involves the ear pinna and there is redness of the ear pinna, don't think about nervus intermedius neuralgia, think about red ear syndrome. In terms of treatment, pretty much the same, quite disappointingly, but you have to remember that this flow chart is based on pretty much very small case series, okay? So we've got our anti-neuropathic, we've got our microvascular decompression, which we had a few patients with nervus intermedius neuralgia that responded really well long-term, and to microvascular decompression. And if there is no neurovascular conflict, then the usual sort of more destructive procedures can be used. Remember, for this very rare form of cranial neuralgias, the diagnosis and the treatment should be preferably undertaken in specialist facial pain centers. Now, occipital neuralgia, which is less of a facial pain, but I think I would like to quickly address that before moving into the unknown territory of chronic facial pain. But I think is important because, again, occipital neuralgia seems to be a straightforward diagnosis if you look at the IHS criteria, but very often is misdiagnosed. Very often is overdiagnosed, very often is misdiagnosed with migraine or other cervicogenic headache. And so it's really important that we don't get this diagnosis wrong, okay? So we're talking about a neuralgiform condition, so paroxysmal attack, short-lasting, quite severe, shooting and stabbing. Normally, the pain is unilateral, can rarely be bilateral. Quite often, the pain has to have either positive sensory occipital nerve dysfunction symptoms, like dysesthesia, allodynia, tenderness in the affected area, or if you palpate the emergence of C2, which you can see in the picture, that's quite tender to the pressure. Now, you know, some of you may think, well, but that's happened quite often in migraine too, and that's true, right? And it can happen in myofascial pain. It can happen in other form of cervicogenic headache with facetogenic biology, for example. But that's why it's important that we phenotype these patients very, very carefully. And one thing that can help us is actually using a diagnostic GON block with local anesthetic only to abort the pain transiently. And you can see, you know, there are three different branches of the occipital nerve, C2, C3. Normally, the GON is the more involved. Sometimes you can have a GON and lesser occipital nerve neuralgia together. And you can see the territory, and you can look the anatomy. But you can see, going back to the otalgia, how the greater auricular nerve starts from C2, C3 actually, and then it moves towards the ear pinna, and that can be a confounding problem when it comes to occipital pain with radiation to the ear. Now, again, I quite like the differential diagnosis of this condition, because I think is what as neurologists should do better. And so migraine and cervicogenic headache are the most sometimes challenging condition that has to be put in differential diagnosis because of the territory. Okay, we know that migraine in 40% can be predominantly occipital. We know the cervicogenic headache is cervical occipital, and so we look at the side. Occipital neuralgia predominantly unilateral. Cervicogenic has to be unilateral. Migraine normally is bilateral, or quite commonly is bilateral. The pain quality, neuralgia form in occipital neuralgia, non-neuralgia form and more neurovascular in the other two, okay? Duration, short-lasting occipital neuralgia, longer-lasting migraine and cervicogenic headache is often continuous, especially if the biology is facetogenic or discogenic. And associated symptoms. So, as I said, there is an overlap between occipital neuralgia and migraine, and you know, why not? Sometimes they can coexist. But remember, occipital neuralgia is quite rare. Okay, so I had a patient that had quite a history of migraine, this sharp shooting occipital neuralgia type of pain, responding to triptans very well. Okay, so what is that? You know, is it the migraine process that has caused a sensitization of one of the occipital branches that responded to triptan? It's difficult to say, but before you diagnose occipital neuralgia, please, you know, rule out something like migraine, which is much more common. Tenderness. So the examination is tricky. We've got tenderness in both occipital neuralgia and migraine. In cervicogenic headache, normally there is a reduction in the cervical range of movements. Okay, which, you know, is more in keeping with a cervicogenic component rather than the other two. And the diagnostic blocks, you know, I think it is supposed to be helpful, but sometimes it just adds to the confusion, because, as you know better than me, greater occipital nerve block, even with local anesthetic only, can be helpful in migraine. And sometimes in cervicogenic headache too, although it's not diagnostic. And so it's important to do that and to try and rule it out, but keep in the background of your mind always the possibility that you have either migraine or cervicogenic headache, which normally you can rule out with more middle branch blocks, for example, in case the biology is facetogenic, which is quite commonly the case in cervicogenic headache. Now, treatment, similar. So you've done your diagnostic block, you've got your antineuropathic. There are some small series of botulinum toxin, not using the pre-end paradigm, but focusing more on the occipital-temporal cervical district. If they are refractory to this treatment, then we know that pulse radiofrequency of the occipital nerve has got some evidence. Minimal invasive, 50% response rate at 3 months, so can be repeated. That's an option. Radiofrequency ablation, it's a little bit invasive and destructive, but it has got some data. And occipital nerve stimulation can work, and is a treatment that, if you've got the people to refer, has got a good response rate. Again, the studies are methodologically quite weak, but the evidence are supportive for this type of treatment paradigm. Now, if we move to the last couple of topics, so the painful trigeminal neuropathy, which are, I think, are really important causes of facial pain. We come across them quite often. And essentially what it means that there is a nerve damage, which can be in any part of the trigeminal nerve pathway, from the peripheral to the ganglion, to the central nervous system. Okay, so we normally, when we talk about painful trigeminal neuropathy, we focus more on the brainstem area and on the peripheral side, part of the nerve. And you know that the most common is post-traumatic, but there are it's quite well known that herpes zoster can cause a postherpetic neuralgia or neuropathy. Herpes zoster affects the first branch of the trigeminal nerve quite well in 10–15% of patients, and has got the typical manifestation: pain initially, after a few days, the typical skin lesions, severe allodynia. There are a variety of different mechanisms by which the virus can damage the trigeminal system, but essentially you get this picture of trigeminal neuropathic pain in the distribution of V1 with the vesicles that quite often in a proportion of people remains, and it can be quite disabling. We've got inflammatory conditions, and then we've got rarely patients where we do all our workup investigation and we find nothing at all. Now, so we say that is common, but how common? So we're talking about the fact that quite often a traumatic injury of the trigeminal nerve can cause a temporary pain in 3%, but the reality is that it persists in a very small proportion of patients. Okay, and normally the pain follows the dermatome. It has the typical neuropathic features with a positive and negative sign of trigeminal dysfunction that needs to be present. It can mimic sometimes atypical trigeminal neuralgia, in the sense that you can have your dull burning pain with superimposed, short-lasting, either spontaneous or triggered paroxysmal pain attacks, or both. But normally there isn't a refractory period, and the pattern is typical of neuropathic pain. So better in the morning, doesn't disturb the sleep, worse towards the end of the day, and made worse by environmental factors. This is not my field, but I have the pleasure of working with an excellent oral surgeon who teaches me every day what the possible causes can be. And we know implants can cause it, molar extraction can cause it, root canal, local anesthetic injection can also cause post-traumatic trigeminal neuropathy, which normally affects the lingual nerve or the inferior alveolar nerve, branches of the mandibular nerve. And the mechanism of pain can be a trauma directly, a pressure from bleeding, for example, which causes ischemia, a chemical injury from the preservatives of the local anesthetic or the other substances injected. Okay, the problem is that we're talking about, for those with persistent post-traumatic trigeminal neuropathic pain, the management is quite disappointing. The research is not great in terms of treatment. We normally have to deliver bad news to the patient, because only a third of the patient reports some improvement, which is significant in a very small minority, and quite often the pain remains, and for years. There is a study up to, I think, 13–15 years. The way we normally manage it is in a multidisciplinary setting, with a mixture of pharmacological treatments, antineuropathic, topical treatment, lidocaine, capsaicin. If remember, the post-traumatic trigeminal neuropathy was also divided into the intraoral variant called atypical odontalgia, and so which now is not considered a diagnosis anymore. But if your trigeminal pain is predominantly intraoral, then there are some cases of intraoral botulinum toxin being effective. And then in some specialist centers, some people use neuromodulation for the very refractory cases. And the last topic, which I think deserves a few slides, is persistent idiopathic facial pain, because it's one of these conditions where we quite often get frustrated, and our patients more than us. And persistent idiopathic facial pain technically should be a diagnosis of exclusion once you've excluded everything else that I've just mentioned. So you have seen your patient, you've done your ENT, maxillofacial, all the scans, dental scans, and nothing, MRI, nothing comes up. There is no biology, there are no features that will point towards a neurovascular component, a neuropathic component, a mixed biology, so that you can say, okay, fine, I'll try this treatment, and because of this characteristic, and see what happens. So technically, that should be the meaning of this diagnostic term. We're talking about a long-lasting condition. Normally, can be one-sided. Sometimes it can be bilateral. The pain is dull, aching. Neurological examination are normal. There are no technically sensory symptoms. The dental causes are excluded, and it seems to be a rare condition, but we see this patient quite often in the tertiary setting, about 21% in one study, and it depends on the level of the specialty. Of course, you will see more or less. One of the frustration for our patient is that the persistent idiopathic facial pain is associated with fibromyalgia, or chronic widespread pain, irritable bowel syndrome, chronic fatigue. A good proportion has got anxiety and depression. And so it's quite easy for most of the clinicians to label these people as people with mental health disorders or psychosomatic problems. And I think, although it's important to understand the mental health problem and manage it, and manage expectation and coping strategy, it's also important that we move away from only that aspect and try to really research the biology of the problem, because otherwise we will always be stuck with these patients. Quite often, the persistent facial pain is associated with a headache disorder, like migraine, tension type headache, for example. And so quite often the facial pain can, because they, of course, sharing the same trigeminal cervical and trigeminal vascular system, can have some feature of migraine, and then we think we're dealing with a form of facial migraine, but then nothing works. Okay, so it's really important to understand that aspect of the condition too. And as I was saying, differential diagnosis is pivotal. Dental oral causes, because of the atypical odontalgia problem, they need to be ruled out with proper X-ray, dental CT. Sinus pathology needs to be ruled out. I found one patient that had a contact point headache, which is vanishingly rare, but I tried 22 treatments with him and nothing worked. He went and did a FES procedure and he became pain-free. And so I felt quite bad about it, but it was a lesson to learn. And I think it's important that you don't stop, and you always seek a second opinion if you're not sure, and if you think that your patient's symptoms are really genuine and they deserve more investigations. So TMD needs to be ruled out. If there is swelling of the face, you have to rule out salivary gland disease. And remember, if your persistent idiopathic facial pain is unilateral, paroxysmal, with some of the TSE procedure, characteristics, try to rule that out, okay? An indomethacin trial is potentially helpful in some cases. If it's bilateral and you think is more likely to be put in differential diagnosis with migraine, then remember the migraine can radiate to the face in 40% of patients, and it can be exclusively facial in 2%. Okay, so you can have migraine in the face quite rarely that responds to triptan. So if you feel that that's the possibility, a bit of throbbing pain, then try a triptan trial. It may not be effective, but if it's effective, then you can go down the treatment route of migraine. Of course, persistent idiopathic facial pain is quite often put in differential diagnosis with painful trigeminal neuropathy and trigeminal neuralgia with concomitant persistent facial pain. And you can see as you know, for what I said to you before, that there are some signs and symptoms that can discriminate the two and enable a diagnosis. Not all the time, I have to say, but in the majority of the time. The problem is, because of this very intimate overlap. There are some people that think that persistent idiopathic facial pain is a continuum with trigeminal neuropathy, where the neuropathic features are less prominent, okay, but it's still a form of neuropathic pain with duller, let's say, neuropathic symptoms. And in terms of pathophysiology, we know very little. We know that the neurovascular conflict of the trigeminal nerve doesn't play a role, and that has been shown by the Danish group. We know that there may be an hypofunction of the dopaminergic pathway, but again, that has been shown also in burning mouth syndrome, for example. But again, these are very initial evidence of a PET study, but it's important to keep it in mind. Other neuroimaging studies show changes in the pain neuromatrix, which are typical of chronic pain disorders, and so that's quite puzzling, although not entirely unexpected. And then some quantitative sensory testing studies have shown some neuropathic features similar to trigeminal neuropathy. And so some people have thought, because sometimes persistent idiopathic facial pain can start from a operation, a dental treatment, then perhaps is a facial form of CRPS, okay, which it's an open field, and I would like to hear from you about that too. So just to conclude, so in terms of treatment, if we don't know the biology, the treatment has to be, unfortunately, quite disappointing. And there are no pharmacological options like hypnosis and CBT. They've got some evidence. There are some small and inconclusive RCTs with tricyclics, venlafaxine, fluoxetine, lamotrigine, topiramate, sumatriptan as an abortive treatment, which is a little bit difficult to position, given that we're talking about persistent continuous pain, but that's all we have. There are some evidence with the SPG pulse radiofrequency, although I'm not entirely sure what population they studied, because I would do an SPG pulse radiofrequency if my persistent idiopathic facial pain had some parasympathetic component, okay, and that justifiable. If it doesn't, is a little bit less, I would say. And there is some new evidence in neuromodulation using TMS, which is quite interesting and worth exploring further. So I hope I showed you the complexity of the field, but also the opportunity that we have as clinicians, as a community, to try and improve this fascinating field of medicine and improve the quality of life of our patients. Thank you very much.
Thank you so much, Dr. Lambrou. This was very interesting and very informative, and I really enjoyed it. And to all in the audience, this presentation and last presentation, we are recording it, so it will be available on the IHS website for IHS members. Now we'll go to the Q&A session. We have more than close to 30 questions. We'll see how many we can answer, so maybe we can try to answer it as short as possible. I think we'll start from the top. We have a question from Betul Baikan, who asked about lacosamide, so an anti-epileptic, also called Vimpat, and it's a sodium channel blocker. Can it also help in the acute treatment of trigeminal neuralgia?
I can take that. I have no experience with that, but I guess that all sodium channel blockers have the chance to work there. So it could be tried, but we have no experience with it at our center.
I can add quickly that, so yeah, it's we have used it with my colleagues at Queen Square in Sankt and Suna, and it seems to work quite well. So I suppose it would probably has a place in trigeminal neuralgia too.
Very good. And can I ask the next question that was actually asked by a few people in the forum? What about Botox in trigeminal neuralgia? Where will you inject? How effective is it in terms of saving patients from going to a surgical option afterwards? And do you think it's good for any other facial pain conditions as well?
I can take that. We use it quite a lot in our center, and I would say that we give it following the pain. We do not use it as we use for preempt, not at all. We simply go for the pain, and I will say on average I use about 100 units of botulinum toxin A. What we have to avoid is to go to central in the second branch of the trigeminal nerve. Then you could give a paresis, but if you keep in the periphery, then it works quite well. I would say that it works in about 50% of my patients, and I use it quite a lot in trigeminal neuropathies because they are so difficult to treat. With regard to whether it saves us for MVD or other surgical procedures, I would say no. If I have a patient that is that are considered eligible for surgery, I would go for that first. So it's mainly in the patients where surgery does not work, and where the medication does not work. There we use Botox, but I think it's quite helpful. And as I said, especially perhaps in the non-trigeminal neuralgia pain disorders.
Yeah, if I can add quickly, I think I totally agree. I think the problem with the evidence in TN is that it's quite difficult to put together a proper RCT. But Botox works for neuropathic pain. There is no doubt about it, and in fact, it probably works better than in migraine. If you look at at some of the evidence published about 12 years ago, for trigeminal neuropathic pain, it works quite well, especially if there is a lot of allodynia. So, because that's where Botox works quite well, and normally it's done a centimeter apart. You can put a grid on the patient face, do it subcutaneously, and as Lars said, no more than 100 units, and it works fine. The problem is repeating it every 3 months. But if you've got no other options, is a good possibility.
Thank you very much. So the next question is from Professor Maurice Levin. He's asking about surgical techniques for trigeminal neuralgia. Have you encountered, in what technique have you encountered the highest incidence of anesthesia dolorosa?
I would say in the ablative procedures, we don't see it. I haven't seen it in microvascular decompression, but in some of the ablative procedures. And our neurosurgeons, they use either balloon compression or glycerol rhizolysis. And I've seen it in a few with glycerol, but it's very rare, fortunately, because it's a really bad thing.
Yeah, I have to say I agree, and you see it quite often if you repeat the procedure. So in people that have more than one ablative procedure, then the risk increases, and then when you have 2 or 3, then the risk of anesthesia dolorosa becomes a problem, and so you have to sort of take that into account when you offer a repeat procedure to the patient.
Giorgio, the next question I think is for you, from Joseph Palubo. Is there a role for spinal cord stimulation in trigeminal neuralgia, or let's expand it to other facial pain disorders? So
look, so technically high cervical spinal cord stimulation, although we don't exactly know where we stimulate, we are close to the trigeminal nucleus caudalis technically, although there is quite a lot in between the epidural space and that area. The idea of not going to the allodinic and hyperestasic area and stimulate peripherally is good, because we know that can cause overstimulation and can cause pain, and on top of the neuralgia from pain. Normally, spinal cord stimulation doesn't work really well for paroxysmal neuropathic disorders. It works more for continuous. So a role in trigeminal neuropathic pain, post-traumatic, inflammatory, or idiopathic, yes. Potentially yes, although we need studies. Role in trigeminal neuralgia needs to be explored.
Great. So we'll go on to a question by Sai Kok. Is neurovascular contact other than the root entry zone, that means distal to this, for example, the intercanalicular, is that a significant finding?
Not in our center. I think it's quite rare. It's nearly always in the transition zone where you get the problems. That's our experience.
Good. And can I ask, we discussed a role for Botox. What about greater occipital nerve block? Is there a role for GON blocks?
We use it sometimes in facial pain patients, but I think it's definitely much more effective in cluster headache and attacks. So I use usually Botox. It's quite rare that I use gun, but sometimes, but it's quite rare.
Yeah, I agree with that.
Great. And then the next question, that's about combination treatment. So what is your preferred combination drug with carbamazepine?
I would say that we usually use gabapentin as the drug of first choice, but sometimes also pregabalin and lamotrigine. That's mainly the three drugs we use.
Agree.
Hossein Ansari is then asking a question about DTI MRI sequences. Can you comment on their role?
I think that it could be of interest in the future, but we don't use it clinically in our center, but it would be very interesting to develop that.
And I think if I can add, Lars, there has been quite a lot of studies in TN with very mixed results. And the idea is to try and understand if the vascular contact caused these diffusion changes in the sensory root of the trigeminal nerve, which you pretty much know. The other potential role would be as a predictor of response to MVD. But the problem is pretty much everyone responds to MVD in any case if they've got a proper conflict with morphological changes. So I think, you know, to use it in clinic is probably debatable. For more research, I think there is a chance that DTI may MRI with DTI may play a role.
Thank you. So next question comes from Yumane Krajne. How frequent are you faced with patients who are allergic to carbamazepine? And if you have a patient who's multiple allergic, for example, penicillin and NSAIDs, would you try carbamazepine or go straight to gabapentin?
I would say that it's quite rare, but of course we see them. What I would do, because carbamazepine and occipital are so much more effective than gabapentin, so I would try with a very, very small dose.
And can I get your opinion on multidisciplinary approach? This is a comment from Professor Joanna Zakroczka, and she's commenting that we don't just need neurosurgeons, but also psychologists, clinical nurse specialists, patient support groups, given that the impact of trigeminal neuralgia on patients' lives is significant, and they often need a biopsychosocial approach.
I completely agree, and we also use psychologists, we also use physical therapists for our patients, and I think also that the patient organizations are very important, so I completely agree.
I think if I can add, Lars, I totally agree. The only issue with that is that not all the centers have got the availability of all these specialists. And I had this chat with Joanna several times, and we agree with that. The thing is, there are two aspects here. One is that I think it's really important that facial pain and trigeminal neuralgia are they are of interest for neurologists, because over time there has been it has been a bit abandoned. Okay, because of the complexity, because of the lack of the biology. So we really need to get it back and get more interest, because that will benefit our patients. And secondly, there are some people that unfortunately they barely have a neurosurgeon, and so it's good that there are support groups that we are all aware and we can refer them, and that's really important. But I think it's also important that we draw the attention of as many clinicians as possible to the complexity, to the importance of these conditions.
Thank you very much. We'll go on to Garik Yeka9, who's asking, what is already known on using CBD for trigeminal and other neuralgias?
I would say nothing. we don't use it. Do you, Giorgio?
No, but my patients do.
Yeah, some of my patients do, but we don't offer it to them. I don't think it works, to be honest.
Okay, very good, thank you. Should vascular compression be considered as a cause of secondary NT? This is a question from Lucas Bonanco.
Oh, yes, that's a very good question. It is a little strange that we call this primary TN, but that's the way that the classification has made it. It might actually come under secondary TN, I agree. It's not logical that it's primary.
Perfect, thank you.
And now we have an interesting question from Professor Manjit Mathau, and it's really something that can be discussed a lot, and it's about SUNCT and SUNA. They have a considerable overlap with TN and are very difficult and are very different from other tags. Should SUNCT and SUNA be reclassified under cranial neuralgias?
That's something that we've discussed a lot, and I cannot answer that. But quite often you can be in doubt whether the diagnosis, what it actually is. And I know Georgia has just published some very nice papers on that.
So yeah, I mean, we publish with Prof. Matharo quite a lot, and I think, you know, it's a fascinating topic by all means. And if you just think that SUNCT and SUNA are the only TACs that can be triggered by cutaneous or intraoral stimulation, that must mean that there are some pain mechanisms that differ. And you look at the prevalence of the neurovascular conflict with morphological changes ipsilateral to the side of the pain, and that's quite relevant. And you know, we theoretically think that that's not the case for the other TACs. You look at the treatment response, and it's completely different. Think about the response to steroids, for example, which is quite important in cluster, and nil in SUNCT. Think about the response to indomethacin. Think about the response to triptans, for example. And on the other hand, think about the response to carbamazepine, oxcarbazepine, lamotrigine in SUNCT and SUNA and trigeminal neuralgia. So the overlap, I think, is there. I think we need more evidence before we can consider a change in classification. But I think it's such a fascinating topic with new emerging evidence, and I think we need to take that into account.
Thank you, Giorgio. We have one more question from Professor Mataru. How many oral preventive treatments should be tried in patients with trigeminal neuralgia and significant ipsilateral neurovascular conflict before considering the microvascular decompression? Lars, maybe you can answer that. Do you have certain guidelines?
Yes, what we do in our center, we will try carbamazepine and oxcarbazepine, try the best of them, and then we would add at least one, for example, gabapentin. If that doesn't work and we can find out very fast, then we will refer this patient for surgery, especially if it's a male. We know that there are better chances of a good outcome for surgery for males. If it's a woman without, just with a simple contact, then we would try more drugs. So it also depends on the degree of neurovascular contact and the gender. And very much on the patient. Some patients, they are very keen on operations, and others, they would really try all drugs before they like operations. So it's very much depending on the patient preference.
That's
also
a very good point, actually, to highlight that the patient preference is also important here.
Yes, and another good question from Professor Mathau. In patients with idiopathic TN who have failed all preventive treatments, how do you decide which neuroablative procedure to offer?
I think that's quite simple. You should use the one that your neurosurgeon has the largest experience with. I think because we don't know, there's no evidence that any ablative procedure is better than the other. So you have to use the one that your neurosurgeons, they are most experienced with. That's my opinion.
I think the other thing you have to keep in mind how serious the condition is and how decompensated, because you know the gamma knife takes a bit of time to work and is not readily available. So it may take 3 to 4 or 5 months. So if your patient is really struggling and you don't know what to do, maybe a glycerol injection or something similar that has a more quick onset of effect would be preferable.
Very good. Lars, I think the next question from Hossein Ansari is for you. Is phenolpalatine ganglion neuralgia a valid diagnosis or entity? In US, some headache and pain specialists use this term quite often.
I have not seen any that I would give this diagnosis, so I don't think so. What about you, Giorgio?
Oh, I think this was in the past. Some of the TACs, and especially cluster headache, was called as phenopalatin ganglion neuralgia because of the sharp, excruciating pain and the cranial autonomic features. So, you know, we are much more advanced now, and I think we you know, the International Headache Society classification clearly states what this should be called, and I think this term should be abandoned.
Okay, thank you very much. If it's okay with everyone, I think maybe we'll go 10 more minutes. The next question goes to Dr. Lambrou, and you mentioned gun block as a diagnostic tool in occipital neuralgia. I find them therapeutic as well, particularly if used in a series once weekly, for example, several rounds. So that's from Professor Morris Levin.
Yeah, so definitely. The evidence show that there is about a third of patients that can be managed with repetitive gun blocks. If you use them with local anesthetic only once a week, it's okay. What I normally tend to do when I use it with local only, I just do the first one, see how long it lasts for, and then as soon as the pain comes back, then I know roughly what the length of the improvement is, and then I carry on like that. So if someone gets a 3-4 weeks, then I repeat it every 3 to 4 weeks. Sometimes there is an accumulative effect, and sometimes if you add steroids, you can get a longer improvement. If the improvement wears off over time, you can use PRF of the occipital nerve. Sometimes that can add on a 3 months long improvement.
And maybe we can add on this a question from Professor Einur Oz. What is your choice of gun blocks in the management in addition to diagnostic blocks? We are here, the comment is that we are in preference of bupivacaine for occipital neuralgia plus dexamethasone, and works quite well.
Yeah, so that's fine. You can mix methylpred, dexamethasone with bupivacaine 0.25 and or lidocaine. We normally avoid triamcinolone because we showed in with Prof. Matharu in a Queen Square that the using triamcinolone, which is less soluble in water, can increase the risk of alopecia areata. And so you know, in case of peripheral nerve block with very little subcutaneous tissue, we prefer dexamethasone and methylpred rather than triamcinolone.
Thank you. The next question comes from Garrick Yiganayan. How to treat pain syndrome, including in the face after a thalamic stroke?
I would say that I would treat this as the pain that it mimics. If there's paroxysms like in neuralgic pain, I would use carbamazepine or oxcarbazepine. And if it's more constant pain, I would use drugs like gabapentin, pregabalin, lamotrigine. So depending on the pain quality.
Next, we have a comment from Laura Abel. To summarize the comment, it's about using fillers, facial dermal fillers. So her comment is that, of course, you may find different expertise in the community of people injecting these fillers, but usually they should be excluded in patients with neuropathic pain, to your opinion, because they can cause different complications. Do you have any comments on this?
Yeah. So I totally agree with Laura. I've seen a few cases myself, and it caused trigeminal neuropathic pain, absolutely. And which then, when they are removed, it remains, and then you treat it as a post-traumatic, I would say, neuropathic pain. And then, of course, you always have the two different scenarios, right? You've got the people that recover, you've got the people that for probably biogenetic, psychological reasons, the pain persists, and then it becomes one of these sort of difficult to treat, long-lasting post-traumatic trigeminal neuropathic pain that we struggle with.
Thank you. So the next question comes from Dr. Matthias Poppet. Interesting question. What would you suggest for treatment of TN in the emergency setting? So in a scenario where there's no phenytoin IV to give and no block to give in the middle of the night?
I would say we don't see that so often because we usually use this phosphoenzyme loading. But what you could do was to make a very rapid increase in the usual drugs. And I have in a few cases where it was contraindicated to give phosphoenzyme, I've used valproate in large doses. Sometimes it helps, but it is difficult. So either increase the current medication and admit them to the hospital because they will probably get a lot of side effects, or try to load with valproate.
The other thing, if I may add quickly, so if the patient is not too old, there is some sparse evidence using sumatriptan injection. And I think I don't have a particularly positive experience, but if there is no contraindication, that could be used. And the other thing is IV lidocaine, which is probably more readily available in some of the hospitals with heart monitoring. That can help, although the evidence are not very strong, as a 45 minutes infusion, people with neuropathic and neuralgia from trigeminal pain.
Well, thank you.
Yes, the next question is about facial pain after a dental procedure where the dental cause is excluded. How can you differentiate between post-traumatic painful neuropathy and new onset TN?
That's a very good question, and a question that we quite often pose ourselves in the clinic. It's important because even if they exclude dental causes, then it could be the local anesthetics that have been used. So I'd see this depends on the timing. If the patient had no pain before and then they developed facial pain just after the procedure, then I would call it post-traumatic.
Very good. Another question from Jessica Milena Rojas Villegas. Many patients with chronic migraine mention pain in the ear. Do you consider that the neuralgia of the intermediate nerve could be a complication of migraine as a form of allodynia, perhaps?
I think remember the trigeminal nerve innervates part of the ear, the superior lateral part of the ear pinna, and also part of the auricular canal. So it's possible that in someone with migraine, the pain radiates to the ear, especially if there is a facial radiation in general. I wouldn't consider that a neuralgia unless you have clear sort of characteristics in keeping with a neuralgiform condition. And remember, the Nervus Intermedius neuralgia is vanishingly rare. So it's more likely that if you've got ear pain in the context of chronic migraine, it's going to be a radiation or biologically linked with the migraine rather than having the two conditions together, which is very rare.
Thank you. There are so many excellent questions. If it's okay, I think we'll just can we just take the last few questions, but we'll answer no more questions than these, and then we'll stop. Is that okay for everyone? Because Maria Kosha asked for any options for TN treatment during pregnancy.
Yes, that's a very good question, and I've discussed that with our epilepsy doctors. And what I have done in those of our patients is to use carbamazepine in as low dose as possible, and then it's important that you add folic acid, 400 micrograms. And in the last month of when they're pregnant, you should use vitamin K. That's what we do. So carbamazepine in as low dose as possible. That's what we use in our center.
Yeah, and I think you could potentially use a low dose of lamotrigine too. And the other thing that you could potentially we do sometimes if you have a V2 TN, you could consider an ultrasound guided V2 block, which we use quite a lot in our center. If it's V3 only, it's a little bit more difficult, and I think you should probably manage it as Lars suggested.
Very good. Next question from Christopher Blatchley. when using occipital Botox injections for cluster headache, are you injecting it deeply as if you were injecting steroids for gone block?
I don't know if you want. So occipital Botox for cluster headache, I'm not sure we use that. So Botox at the moment, as it is injected in trigeminal neuropathy and migraine, has got no role in cluster headache. There may be some new potential ways of injecting Botox in more meaningful structures of the trigeminal autonomic system, but at the moment Botox is supposed not to be working that well in cluster headache. So we would much rather use greater occipital nerve blocks with steroid and local anesthetic, as it was pointed out.
I agree. I also don't use Botox for cluster, but I actually, in some patients with facial pain, I actually inject Botox over the gun, and I use it subcutaneous there. It's my feeling that it works, but there's no evidence for that.
Second last question from Don Malicia. Can migraine be considered a risk factor for neuropathic or facial pain?
So, look, I don't think we can clearly answer this question. You know, theoretically, if you think about the system that is used, so the trigeminal cervical system, if the system is already sensitized because you've got migraine and you have any sort of dysfunction of one of the peripheral branches or central areas of the trigeminal system, then you may assume that is more likely to develop orofacial pain. The other thing I showed in the talk is that about 40–45% of patients with trigeminal neuropathic pain or persistent facial pain has a history of primary headache, quite often migraine. So that potentially could suggest a biological or a risk factor link. There are other risk factors like gender, like social issues, mental health disorders, for example, or having pain elsewhere. So I guess the answer is, broadly speaking, yes, it could be, but we need proper research to establish that.
Okay, and last question from Joseph Palubo. What dose of lidocaine will you use for IV infusion?
There's only one study, and in this study they used 5 milligrams per kilo infused over 60 minutes. So that's what I would use. But we use phosphonitrin in our center. But 5 milligrams per kilo.
Yeah, thank you, Lars.
Thank you. So that was the last question. I think we went through more than 30 questions. So thank you so much for all the attendees for watching this webinar, but also asking so many good questions, because I think they were all very clinically relevant and also very interesting. Thank you so much to Dr. Lars Benson and Dr. Giorgio Lambrou for excellent presentation and excellent answers to these questions. Thank you so much to my co-host, Anna Andreu. We'll be back with more webinars in IHS. If you have any suggestions for topics, please let us know. So thank you so much for attending and have a good evening.